Good morning, and welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stine. I'm a family physician here in Vincennes, Indiana, and Chief Medical Officer of Good Samaritan Physician Network. With me, as always, Adam Thacker, who's our Chief Operating Officer of Good Samaritan Hospital. We'll be giving you our weekly update on status of COVID-19 in our community, talking a little bit about our usual subjects, which, of course, this week will include vaccination, what we've been doing with our monoclonal antibody infusion over the course of the past few weeks, and then kind of what to expect over the next month or so. So starting off with statistics, around 2,500 total cases that we've had since the beginning, and around 400 active cases right now. The positivity rates always tend to be our hot topic every week to say where we've been and kind of where we're headed, because things have really been pretty rough over the course of the past few weeks or so. Our positivity rate with all individuals running around 15%, and then with unique individuals, which is a little bit better judge of what each individual person has had over the course of the past 7 days, has been around 30%. The other thing I think this is an interesting statistic is one that you brought up, which is the subject of how many within the last 30 days, 60 days, 90 days of that 2,500. Can you comment a little bit on that today?
Sure. Yeah, over the last few weeks, really, and watching it, we've seen better than 50% of our total cases have been in the last 30 days. And as that continues to move forward, that continues to be the case. So we're really seeing that steady, sustained transmission across our community. And when we start to look at it and say 50% of our 2,500 cases have happened in the last 30 days, 1,200 plus cases, that's pretty alarming, because as you and I have commented on, and we know very well, is that's a leading indicator to say how many individuals are going to end up requiring inpatient care and acute care. And that's certainly where we start to get a little more concerned with resources, even though we know the vast majority of individuals recover at home and do very well. As that number of positive cases and active cases is creeping up, there's a percentage of those that will require intervention, whether it is an outpatient treatment, which still requires a lot of resources, or whether it is inpatient care, which we know can be a long length of stay and a difficult recovery for some. So it's just continues to put, you mentioned vaccination, but it continues to put, right now, the focus remains our social distancing, our hand hygiene, our wearing of our masks, doing the things that we can from a public health standpoint to protect one another.
And certainly we had anticipated, as we had after every holiday, that there was going to be a surge post-holiday. And absolutely in the ambulatory world, we have seen a tremendous surge in the numbers of positive patients, in the number of people that are very sick in the outpatient world. Thankfully, we haven't seen quite as many of those patients that have required ventilation and admission to the hospital. But that kind of leads us to where we've been with our monoclonal antibody infusion over the course of the past 3 weeks or so. So about 3 or 4 weeks ago, we were fortunate to get the first shipments of the monoclonal antibody bamlanivimab. We started off with that one and are now utilizing that along with Regeneron, which is the cocktail product with 2 different monoclonal antibodies in it. That is being used just in the ambulatory world, and that's how this was studied. And the primary purpose behind this is to catch patients early in the disease, preferably within the first few days, not past a week out from onset of symptoms, that are COVID positive, that have risk factors for having poor outcomes with the disease. If you have multiple medical problems, obesity, diabetes, chronic kidney disease, chronic lung disease, immunosuppression, these are all things that put people at a much higher risk for having bad outcomes from the illness. And what we've seen, fortunately, has been some really quick turnaround with patients who have early intervention.
Yeah, we've been very pleased with the success of the outpatient treatment, and happy over the last few weeks. We've had vaccine discussions, we've had outpatient treatment discussions, really looking at some positive aspects of responding to this pandemic, and have been able to give 70 plus treatments to individuals with, believe we're still just remaining at one that had worsened to requiring inpatient hospitalization. So that's a large number of patients that have either their symptoms have kind of maintained for a period of time and then have gotten better and have stayed out of the hospital. And I know you and I have spoken. I've spoken to other physicians who have said that their feedback has been 24 to 48 hours after treatment. They've had a lot of patients say feeling better already and seeing that immediate response, because how this works is this infusion is monoclonal antibody, so it puts antibodies into your system and helps to neutralize the COVID virus from spreading and continuing to wreak havoc in the body. And so it's done its job very well. And interesting comment that I heard last week. We were talking with a group that were working on some different telemedicine, and they were in a different state outside of Indiana, and mentioned that we have administered more monoclonal antibody here at Good Samaritan than their entire state had. And I know Deaconess, south of us, has been a very large proponent of this and pushing it. I believe they at one point were the largest treatment facility that had administered in the state, and we really pushing this just because of what you said. I mean, huge impact that has been able to have, because you've got to think, even if 20% of those individuals ended up in the hospital, that's a large number of patients that end up needing hospitalized care.
And really, that is one of the important things to think about when we talk about who should be getting this, and making sure that patients are aware that if you start having symptoms and you're in one of those higher risk groups, please get in contact with your primary care provider or get to our convenient care clinic, because we really want to try to administer that as early in the disease process as we can. The patients, when we look at from day 1 of symptoms to day 7 of symptoms, the ones that report the quickest turnaround and feel better faster are the ones that are in the first few days of that illness. And so really over the course of the past couple weeks, because patients have learned about this and understand that it's available, our providers know that it's available and how to apply it, we've seen a much quicker turnaround time where patients come in sooner. They're in day 1 or 2 of illness instead of being on day 6 or 7 of illness, and we've seen a much quicker turnaround where they feel better faster.
And important to reiterate, as you mentioned at the beginning of the monoclonal antibody discussion, this is really targeting that high-risk population that are susceptible to the virus being a little bit more difficult to recover on their own. It's not for everybody to go get tested and then say, I want that treatment. We still know that a large percentage of our community will contract COVID-19 and will be able to recover at home, their own immune system be able to fight this virus off. So it's not a treatment for everybody, and that's not necessarily a resource thing that we're holding that back. It's just not necessary for everybody to have this boost to their immune system.
And the important thing about what has changed as far as diagnosis and treatment really has been we have much more rapid, much more accurate testing that's available now. Our point-of-care testing, when you see a provider either in the office or see a provider at convenient care, we have the ability to get that test back within 15 or 20 minutes or so. That then helps to drive that rapid diagnosis and rapid treatment with the monoclonal antibody in that higher risk population. So a lot has changed really over the course of the past just couple months or so in terms of what that available testing is, what we've found to be the accuracy of that testing, which the point-of-care testing is considerably better than what we initially had thought.
Yeah, we've been very pleased with the specificity, sensitivity of the test, and it's really served as a reliable resource that our providers can make decisions off of. We've been able to secure supplies through the state's help and pulling those down here. That's at our convenient care sites, at our medical center of Vincennes, where the majority of our primary care assessment is happening. We can test there. Our emergency department has the ability of patients that are needing that level of care to do these point of care tests that are the 15-20 minute turnaround time. It does require a provider assessment, and it does require that the patient is symptomatic. These tests are not approved for the asymptomatic. I was told I was a close contact and exposed, but I feel fine, I want to get tested. That's an option at our convenient care site, but that is the molecular test. That's a send-off. We're still seeing about a 3-day turnaround time on that, but having that point of care for our symptomatic helps us to really identify those that may be of qualifying for treatment. Also, if somebody is symptomatic, then we know right then, okay, this is COVID, or we're in that season where it could be something else as
Absolutely.
well.
And one of the things that we've spoke about as far as what's the use for the monoclonal antibodies, this is basically a bridge to get us until we have enough of our population vaccinated to provide better immunity to our higher risk population.
Yeah.
And so as we have gone over the course of the past few weeks, that's how this is being utilized, is hopefully we can continue to keep our sicker patients and our more at-risk population taken care of with the monoclonal antibody infusion, as the vaccine is being rolled out. And we've talked about it for weeks and months and seems like even years. But really, over the course of the past few weeks, we've got hard numbers on when the vaccine is being released, what vaccines are coming out, the timeline of that, and then a strategy is laid out as far as who gets the first round of vaccines and from there. So can you speak a little bit to that?
Yeah, very early. I mean, in March, we probably mentioned the return to normal, and the end game, if you will, was a vaccine to protect a large enough population to create what's called herd immunity. And that time is here. So last Friday, the FDA, or last Thursday, the FDA's advisory committee approved the Pfizer product that had been approved in the UK and in Canada just before. And then on Friday, the FDA accepted that and gave what's called emergency use authorization. So it's approved. The vaccine is rolling out this week and will be here at Good Samaritan as a phase 1A distribution site in the later part of this week. So FedEx, UPS are hot on the move and delivering. So if you haven't got your Christmas shopping out of the way and you're expecting deliveries, FedEx and UPS are going to be delivering a lot of vaccines. So there may be delayed other shipments. But we're excited about that. Our first clinic will open up this Friday. The focus is the healthcare workforce first, those frontline healthcare workers that have, for the last 9 months, put their selves on the line and taking care of our vulnerable population battling this pandemic. We're covering Knox, Davies, and Pike County. That has been sent out. Folks are registering for the vaccine. Just an exciting time as we see that move forward. And then by the end of this week, we expect the Moderna product, the second vaccine, to receive the same emergency use authorization as Pfizer, which just adds to more volume of vaccine, allows us to roll that out to more individuals. And then we'll start probably towards the end of January, but some of this is still a moving target. We'll start to look at what's called phase 1B. Phase 1B is essential workers and our high-risk community. Many of those folks that we talk about that should be looking to shelter in place as much as possible. If they do become ill, should be looking for monoclonal antibody treatment as a potential solution. But our high-risk community, those over 65, those with chronic illnesses, that's still being defined, and that won't be defined by Good Samaritan. So I've gotten that question a couple of times. Right. Who are you putting in high risk? Well, it's not Dr. Scott Stine. It's not Adam Thacker. The state, via the federal CDC, government, individuals are saying, okay, this is the population that needs to get that vaccine first, and then there will be a rollout to be able to do that. What we do know is Good Samaritan will be the distribution site for this area, and we'll be getting that information out as we get more direction from the State Department of Health.
And that brings up the point, we've had questions over the past several months. How will I know? Who's going to notify me? How am I going to be alerted to the fact that I should be one of the ones getting the vaccine? We've kind of been preloading all of our patient population with our visits in the office when we see them to say, hey, because of your chronic kidney disease, because of your chronic lung disease, you're going to be one of the people that should be earliest vaccinated because of these at-risk issues. And so as Adam was discussing, the structure of that is not exactly defined, but we have that education process. We're talking to our patients to help them understand these are the reasons that you should be considering that vaccine, because early on we want to try to get you vaccinated as quickly as possible. As that rolls out, as that phase 1A and then phase 2 or 1B comes around, then that continues to roll out over the course of the next several months. But really the population that we're most concerned about, the population that's more likely to get more ill, to be hospitalized and be ventilated, that's the population that gets the vaccine really in that phase 1B that you're talking about.
Yeah, we're looking at phase 1A, healthcare frontline personnel, and phase 1B, essential workers and high risk, really being able to get through those two phases by end of March into April. And then we'll feel like the most vulnerable at-risk populations, either those caring for COVID patients or those that have the most difficult time recovering, will have the opportunity to be vaccinated. You hear a lot of discussion of is this, because of the public health measure, is this going to be mandatory, and those types of discussions. At this time it is not, especially under what's called that emergency use authorization. Now, Pfizer has already came out and said by April they expect to have the full-fledged FDA approval. And when that occurs, then there will start to be discussion in the healthcare world as to mandatory vaccines similar to influenza and what that will look like, and then even potentially at a community level what that will look like. But we've still got some months to figure that out.
And every population that we get vaccinated, that's taking one more group off the table that we're concerned about as far as becoming more gravely ill, having enough supplies and resources of personnel to take care of the sicker population. Each group that gets vaccinated, every 100 patients, every 1,000 patients that we go through, that's basically providing closer to that herd immunity. Now, we certainly don't expect herd immunity to affect everybody in such a way that we don't have to wear masks and so forth until we get well into 2021. Right. So many people are asking, when do we get to ditch the mask? When will we see things drop? And it's going to be several months. We fully anticipate, though, that just like the cycle of most viral illnesses, as we hit the spring, things are going to be dropping off anyway. But that population, the ones that we're focusing on the most here early on, is that at-risk, higher-risk population.
And the vaccine was approved for 16 years and older. And so it was not studied in under the age of 16. So when you hear it wasn't approved for that, I think sometimes if you're outside of the clinical world, you think, well, there was something wrong. No, it just wasn't studied in a population under the age of 16 because, as we have seen, that school age group, when they have had COVID, recover pretty easily. Their immune systems fight it for the most part. There's obviously examples where that wasn't the case. And then pregnant women has not been studied in, but I did read over the weekend that they are starting to move into those types of trials. So ideally by mid-2021, even those populations will have some data to say this is recommended or it's not, what that looks like.
Bringing up the kids and school and so forth, when we look at how the schools have done, they've done very well. Our numbers within the school systems have been relatively low. And we've had calls every couple of weeks or so to touch base with our school superintendents and school nursing staff to see how things are going. And thus far, things are proceeding well. We hope to continue through the holiday season and have everybody in session until their normal break off, and then kind of reevaluate in between the holidays, between Christmas and New Year's, to see how things have gone and see how our numbers are looking. So again, we thank all the schools for what a good job they are doing, and the nursing staff for doing a great job of looking at those populations and trying to keep them separated. And that has been a good experiment in how tolerant and compliant the schools are and the students are. And we wish everybody would do that.
Right.
And as we go into the holiday season, as we get into Christmas and New Year's, we ask that everybody think very critically about what that's going to look like, what your family gathering is going to be like. We all kind of have our inner circle of family that we're around all the time. We don't worry quite as much about that. But traditionally, Thanksgiving, one of the biggest holiday times of the year, Christmas, kind of second biggest holiday time of the year, we worry a lot about people that are traveling and spreading the virus around. So we want people to be very cognizant of that and make smart choices about that.
Right. No, as you mentioned, I was talking to my daughter this weekend, wearing her mask in the vehicle with me. I was like, you don't have to wear your mask right now. And I mean, just very compliant. Her response was, I'm not getting quarantined.
Right.
So they have been really compliant. And then on the holiday front, certainly everybody wants to get together for the holidays, but, we would ask again, have that plan. If there is that close unit that you are around, then you're already around but not people traveling in, not traveling out. Looking at that, talking to somebody the other day and just said, we've come this far to this point. What's taking that extra step to get us a little bit further? The vaccine's on the horizon. We're really looking at that light at the end of the tunnel, even though it is a few months away. We're happy to be talking about those steps that we're taking. Right. And so, you certainly don't want to look back at Christmas in 2020 and say, I wish we wouldn't have had that large gathering because 3 people ended up in the hospital or ended up at home for 10 days, 14 days, really sick.
Right. And realize, too, that regardless of what the day is, regardless of what the time is around the holiday season, we have providers that are available to see you. If your primary care office doesn't happen to be open at the time that you need to be seen, we have Convenient Care Clinic that is seeing patients, has the rapid test available, and we can also get on board to get the monoclonal antibody infused. So regardless if you are here, if you are traveling, wherever you are, we would ask that people not stay home and get sicker if they're an at-risk population. We realize that that sometimes gets challenging if you're in another part of the country or you're traveling around, or if family members are in from out of town. But we want people to get diagnosed early, especially if they're in that high-risk population. So please seek out care, get seen at convenient care, get tested, and get treated if that's at all possible.
And that is a great segue into one of the conversations last week around the governor's update on looking at elective surgeries and hospital capacity. I think every region of the state has to look at this differently and see what's going on locally, regionally, and at a state level. And we've been able to maintain hospital capacity. Do not put off care, whether that is COVID related, not COVID related. We're urging not to put off care, because that can have some pretty dramatic effects if you're putting off surgeries that need to occur, because they can worsen, and that makes the surgery more involved down the road, more difficult recovery. If it's a chronic medical disease, allowing that to worsen can pass a point of irreversible worsening. So seek medical care timely. Talk to your providers. They will give you the best instruction on whether waiting makes sense, whether it doesn't make sense. From a state perspective, the executive order was very limited to, or very restricted to, elective non-emergent cases that require an inpatient stay. So that's a pretty small number of all the treatment services that we provide. And when we've looked at that, very few patients are impacted. If that is the case, then your provider will contact you and will say, hey, based off of this, I think we should wait until into the new year. But again, if you weren't contacted, don't take that to mean my surgery is canceled and I should put this care off. We really want you to seek timely care unless your provider has directed you that the best scenario is to delay that care.
And thankfully, the majority of surgeries that are done nowadays are done in the outpatient world. Patients are ambulatory. They go home the same day. Even some of the bigger cases, as far as joints and things like that, are going home the same day and then having close follow-up afterwards. So we saw this when we went back to March, April, and May, that we saw congestive heart failure, heart attacks, worsening of chronic kidney disease, worsening of diabetes, patients who had strokes and they stayed home because they were fearful of what was going on with the virus. We don't want patients to stay home and get sicker. We want to know what's going on. We want to help out and be involved in that decision-making process. So if something's not going well, please contact your primary care provider, get on board with them to determine if you need to be seen in person, if this can be done in a virtual visit. And then again, if it's after hours for some reason, we have the convenient care clinic that are seeing patients every day. Any other things before we move to the phones?
I don't believe so.
Okay.
Right. Got a few this morning. Is the vaccine safe for breastfeeding women?
That's a great question. As far as I know, they haven't specifically studied that. The majority of the time, though, whenever we look at vaccine safety as it pertains to breastfeeding, it is safe. Right. The biggest thing that Adam was referring to there basically earlier was with pregnancy, and it's not that they think it is unsafe for pregnancy. In fact, we think it will be safe for pregnancy, but the first populations that they studied have been our higher risk populations, people who are more likely to get sick with this illness. And so children, adolescents, pregnant women, those weren't included in the first studies. That will be rolling out with the second round, but more often than not, vaccines are absolutely considered to be safe, especially when we look at the technology that's behind this and how that would pertain to breastfeeding.
Right. And the ACIP guidelines, which is the Advisory Committee on Immunization Practices, did not put out any restrictions for that population. While I can't speak to exactly how that was or was not studied, it was not listed in a restriction as that population, breastfeeding women, should not be vaccinated, which tells us that it's approved for that use.
Right. For someone that may have risk factors for complications other than taking precautions to not get COVID, do you have any recommendations to prevent complications should you get COVID, like certain vitamins or anything like that?
Sure, there's not much conclusive data on some of the things that we have heard in terms of vitamin C and vitamin D and zinc and things like this. No question, though, that we have seen that the more active patients are, the more they're ambulatory, the more that they move around, the quicker that they recover, and the less likely they are to get COVID pneumonia. One of the things that we have definitely seen is as people get sick in those first few days, they tend to lay around home, they get more fluid accumulation in their lungs. We see that that is kind of a poor predictive factor. And so one of the things that we encourage patients to do early on is please be up, please be as active as you feel like you can be given the illness. That helps to open up your lungs. Here in the hospital, we use things called incentive spirometers, which are basically devices that help you take deep breaths, cough, and clear mucus and secretions from your lungs. You can do that at home simply with deep breathing exercises, grunting exercises, and coughing exercises. All of those things help to clear out your lungs. But specifically, there haven't been a lot of significant studies that have conclusively said, hey, you should take this vitamin, this supplement, the cleaner for your aquarium, Clorox wash, anything like that. We want to be very cautious about those things and not have people harm themselves with products that are not really found to be useful.
Right. Yeah, certainly anyone who fits in that high risk and starts to develop symptoms, our triage line, contacting provider sooner rather than later, and being on the front end of seeing symptoms. And symptoms, a lot of what we're seeing over the last couple months have been that symptoms start out as, oh, this is sinuses, oh, I just feel a little tired. Anything that's a change, especially for folks in that high risk, if it's a change and doesn't seem like this is a normal seasonal thing, that you talk to a provider, get some advice. We may need to get you tested just to know, or they may give advice on fluids, exercise, staying up and ambulating are really important.
One of the things Adam said that's kind of interesting about this is when we see influenza hits like a hammer. Whenever you become ill with it, you get fever, chills, muscle aches, you feel like you got run over by a train, and it's in a fairly short time frame. What we've seen with COVID more often than not is kind of a slow, innocuous beginning with some mild upper respiratory symptoms, and then a few days into it, the novel I lost taste and smell really has turned out to be a fairly high percentage of the time, interestingly enough. But it can have gastrointestinal symptoms. There can be fever, but not always fever. But almost always there's upper respiratory congestion symptoms and drainage symptoms. Now, we have interestingly seen less of our usual viral illnesses this year, which is because everybody is masked, so we're not spreading our usual viral bugs around. Right. But we're still seeing that to some extent in all the populations that we see.
Okay. Has there been any testing on people that are in cancer remission? I'm not sure what testing is. As far as for the vaccine, they didn't specify.
So we're probably talking about one of either the treatment. Right. So monoclonal antibody treatment certainly is approved for that population and would be a high risk population that we would definitely want to give some boost to the immune system, because depending on how long you have finished your treatment, certainly any chemotherapy or radiation treatment has the ability to zap your immune system, and so this would give a boost to that from a monoclonal antibody treatment. And then from a vaccine standpoint, going back to just very basics, but I'll be quick, is that this is not a live virus. These vaccines, these first two vaccines, are created through that messenger RNA technology that has been developed, so it won't make you sick. It doesn't produce that type of response. It produces an immune response without the illness. So any cancer patient in remission or even in active treatment is still eligible to get the vaccine, and we would definitely encourage that. That's a high-risk population that should go in that direction.
And over the course of the past few weeks, as we have had access to the monoclonal antibody infusion, Dr. Mahan and myself have approved that treatment for several of our cancer patients that are actively being treated, because, as Adam said, this is obviously one of our higher risk populations. So both of those are certainly appropriate, and as we've talked about each time, very important to try to get on top of those symptoms and diagnose this early in the course of treatment.
Is there a concern for people with allergies getting the vaccine? If so, is that drug allergies or seasonal/environmental allergies? There has been some mention of this in the media.
Yeah, so the mention of that, there were two healthcare workers in the UK that had severe anaphylactic reaction.